I want to thank Wadi again. All of us, I think, have interacted with Wadi and probably have appreciated our interactions with him when we're on service or otherwise. And we're also grateful to have you today to talk about fetal cardiac diagnosis, which it's a very broad subject, but I think this is a good opportunity for us to hear what you're doing, what your division is doing, and also be able to ask some questions and reflect on some of the cases that we've shared. So thank you very much for presenting to us. And usually people might post questions in the chat as you're going. A lot of presenters will take them at the end, but you're of course welcome to take them as you're going as well.
That's perfect. Thanks, Jared. I'm really happy to be with you guys. Hopefully, as Jared said, the subject is quite broad. It's kind of meant to give you kind of a window into our world. And it's by no means like just me talking. So if at any point you have questions or comments, you can interrupt me as we go. Or at the end, there's probably a little bit of time to do that. So for today, I'll just start with kind of the broad objectives. So fetal cardiac diagnosis is obviously the cardiologist plays a role in that, but critical, more upstream role is obviously the role of screening in the obstetrical setting. So in this presentation, I'll just do a brief overview of that aspect of the part of fetal cardiac diagnosis, the importance of screening, how to screen, kind of go over briefly the guidelines, and are we any good at screening? And I'll give my take on that. And then we'll arrive kind of more into our world, the fetal cardiologist world in the fetal setting. We'll just briefly review the fetal cardiovascular system because it's relevant to know its particularities, especially when we want to understand the strengths and weaknesses of fetal cardiac diagnosis by fetal echo. I'll go over the diagnostic approach, and as we go, I'll give some examples, and feel free to chime in or to mention any specific patients you want to talk about. And then at the end, I'll go over kind of new promising imaging technology in the form of fetal cardiac MRI and kind of some of its applications. So to start off, the importance of screening. Obviously, we know that this is an important part of fetal cardiac diagnosis because it allows us to counsel the families about what to expect and what we're worried about and what the next steps are. It allows us to detect more complex problems. So once the heart is flagged as an issue, it becomes a gateway to detecting other problems outside of the heart. It can determine the location of delivery, especially in our setting, we're very familiar with that. And then it opens up options for the pregnancy if the parents wish to terminate the pregnancy in the face of abnormal findings. So this is just some data to show that just providing a letter or audio tapes in this particular study reduces anxiety and depression in the families receiving this type of counseling. So it's really an important part to be able to make a diagnosis and provide adequate counseling for the mental well-being of our families. And this is from a center where they compared these scores of anxiety and depression before patients received counseling and after. And you can see that there is definitely a reduction in that after counseling. In our service, we're trying to do this as well with our fetal nurse to kind of quantify that. Over the past few years, we've had the blessing of having Michelle Zegray, that you guys know, as our fetal and transition nurse, and we're trying to quantify the effect that she's had on families. So we're keeping track of that, and in the next few years, we'll be able to study that in a kind of qualitative manner. As you guys know, obviously this is not news. The detection of abnormal heart is one of the very important parts of detecting more complex problems, genetic and other syndromic issues. So proper detection and diagnosis of a congenital heart problem is very important in fetal life for the rest of the baby. Determining the location of delivery, obviously a prenatal diagnosis is extremely helpful, and this is across time, showing that a prenatal diagnosis really favors the postnatal course and outcomes for these babies. And finally, just to show kind of the effects of proper detection of congenital heart disease prenatally, you can see that with time, anomalies that are detected in the four-chamber view, there's a significantly more important part of these diagnoses that end up opting for termination of pregnancy. So properly detecting these anomalies becomes an important thing for families to make the best decisions for their situation. So how is screening done? This is done by our obstetrical colleagues, not across the healthcare system. So there's been multiple guidelines from multiple societies, and these guidelines have progressively become more comprehensive. This is the initial SOGC 2009 guideline, basically advocating for diagnosis of between 18 and 22 weeks of gestation. And it basically just says to examine the thorax, the heart, the lungs, and to do a four-chamber view and relate these to the outflow tracts. So obviously this has been updated over the years. The AIUM in 2013 suggested to start this diagnosis as of 18 weeks, and to, in addition, to store the images, which was not always the case. It could be surprising for us in this day and age, but some exams were, done without keeping any of the images for later review. So this statement brings in the aspect of storing the images to perform four-chamber views, left and right ventricular outflow tract, and to look at the stomach position and the position of the heart within the chest. And later on in 2013, we have the IUSOG guidelines, which include a much more exhaustive, and I won't go on every point, but we'll touch on it a bit later. A much more exhaustive and complete evaluation of the fetal heart between 18 and 22 weeks. This time, advocating for cine loops, which are the movie clips that we use to image the different structures. The use of image optimization, like use of harmonic imaging and ultrasound to improve the image quality, use magnification. So there are all of these technical considerations that significantly increase the detection power of the screening exam. And at that point, Doppler is still not recommended, but obstetricians are encouraged to be familiar with it. So the effect of these screening guidelines was studied across multiple centers. This is just one study from the Netherlands that compared their detection rates pre kind of implementation of these screening guidelines and post. And I'll just attract your attention to the lower box here. You can see kind of a big jump between the total proportion of patients that were detected prenatally from 35 to 59%, almost like doubling, as well as the patients who only have congenital heart disease, that also doubled. So there's a big big added value to having these more exhaustive type of screening protocols. But unfortunately, not everything gets better with time. The gains that we might have made in a technical and technological standpoint come with new challenges of the era. So we know that maternal obesity is associated with congenital heart disease, and we know that, and you can see this here reflected in the odds ratio that increases with the degree of obesity, the odds ratio of having congenital heart disease. This brings with it, obviously, the technical difficulty of scanning obese patients in fetal life, because, of course, our ultrasound has to cross the belly, the uterus, the placenta in some cases, before getting to the heart of a fetus that's moving all around. So this significantly can hinder the ability to detect congenital heart disease, and you can see this reflected in the proportion of exams that are missing, very important elements to the fetal cardiac exam. So you can see here the four-chamber views as well as the right and left ventricular outflow tract views. These are pretty minimal screening views, and you can see, and it's not a big, not a surprising thing, that with increasing obesity, the proportion where these of exams where these views are obtained becomes lower, and so the ability to detect congenital heart disease becomes more difficult. And we see this reflected in our daily practices. When we see these very obese patients, it's very difficult to exclude things with certainty. So that's one of the limitations of ultrasound. So to wrap up the screening part of things, it's mainly addressed at a low-risk population in general. The general population is at low risk of congenital heart disease. It's mainly performed by non-cardiologists. So it has the requirement to identify normal or abnormal. That's the ask. And these detection rates have improved with evolving guidelines, with around 60% of congenital heart disease being detected by these screening guidelines. So 60% may sound not so great, but we have to keep in mind that this has improved over time. But you can see that there's obviously room for improvement, and that's our role also when we do outreach and reach out to our community and our obstetricians who refer us the patients. And that's pretty much it for the screening part of things. Are there any questions so far? I can move on to the next part.
It's great so far, Wadi.
Perfect. So I'll continue on. So the next part is really the life of the part of the fetal cardiologist. So once the patients are screened and identified, they arrive with a referral, and the referral can be anything, just fetal anomaly, fetal heart cardiac anomaly suspected, or a more specific question can be asked. But we're just happy to get, suspected abnormal fetal heart. So for this section, I'll just go over the particularities of the fetal cardiovascular system. As you know, it's remarkably different from the postnatal circulation in that it is a circulation that is organized to function in parallel, meaning, and this is thanks to the interposition of the placenta, which is the only human organ that receives blood from two individuals. The blood doesn't actually mix normally, but it's the only organ that does that. And it's a remarkable organ because it allows this low resistance system to exist and to function in parallel, thanks to the presence of these shunts, or these communications between the left and right circulation. So the ones that we know are the ductus venosus, the ductus arteriosus, as well as the PFO. And in this type of circulation, the right and left ventricle basically pump different proportions of the cardiac output. That's why a fetus who is can be missing a complete side of their heart and still be okay in pregnancy, because the remaining ventricle can pick up the slack and pick up that cardiac output. So that's why a lot of critical lesions are stable prenatally, but after birth, obviously a lot of changes have to happen, and this parallel circulation becomes in series all of a sudden in a few breaths, and so any issues with that circulation might come up. So that's why generally babies are with even severe congenital heart disease are quite stable in utero. So once the babies are born, they go through the transitional circulation, which are the changes that occur right after birth, where the fetus no longer uses the placenta to breathe, but has to use their own lungs. The parallel circulation no longer functions as a parallel circulation, but goes into series. So both ventricles under normal circumstances should be pumping the same amount of blood, whereas just hours ago in the uterus they were pumping totally different amounts of blood. The fetus goes from living in a liquid environment to a gaseous environment, and that also has effects on lung function and structure. So after the first breath, the placental, or when the placental vessels are clamped, the main changes are that pulmonary vascular resistance decreases, pulmonary blood flow dramatically increases, the pressure in the right ventricle and right atrium decrease, the pressure in the left atrium and left ventricle increase, because now there's all of this blood coming back from the lungs, which wasn't there prenatally, and the systemic blood pressure increases. So these changes are quite drastic and quite quick, and it's amazing that happens in all of us. With these hemodynamic changes, the PFO that is initially shunting right to left, right? It's redirecting the placental blood flow to the left side of the heart. With the left atrial pressure increasing, it ends up closing the septum primum flap that pushes against the septum secundum and essentially closes the foramen ovale. As we know, this can stay open in around 20 to 30% of adults, so quite a bit. So it's not a congenital heart disease when that's the case after birth. The ductus arteriosus begins to constrict in response to increased oxygen and decreased prostaglandins that were produced by the placenta. And it usually achieves functional closure within a few hours, few days of life, and then anatomic closure within 1 to 3 months. And the ductus venosus, which is serving to redirect placental blood flow to the right atrium, it constricts, redirecting that flow into the hepatic vessels, and it closes within 1 to 3 weeks after birth in term babies. So that's the circulation, but what about the actual pump, the fetal myocardium? So the fetal myocardium is actually quite different from the adult myocardium in that it's much less compliant. The fetal myocardium also achieves less active tension and maximal force compared to adults, and this is the result of many histologic differences. So the myocytes are said to be immature. There's fewer contractile elements, and you can see this comparison side by side of the fetal myocardium and the adult myocardium, and you can see these striated structures, which are the myofibrils, which are basically the contractile unit within the myocyte. And you can see how much fewer there are in the fetal myocardium. They also have decreased T tubules in the sarcoplasmic reticulum, which we know is heavily involved in calcium cycling, which is primordial for myocardial contraction. And then there's also decreased sympathetic innervation and beta adrenergic receptors on the fetal myocardium compared to the adult. So all of these things make the fetal myocardium pretty much functioning at the upper part of the Frank-Starling curve, which is the volume pressure curve. So you can see normally in a normal adult heart, if you give it more preload, if you give it more volume, it will contract harder or develop more force until it reaches a plateau. And for the fetus is already at that plateau throughout gestation. So the fetus has a very limited capability of increasing his stroke volume because he can't really increase contractility, can't really increase preload. So the fetal heart rate becomes extremely dependent on the heart rate for cardiac output. So fetal cardiac output is much less adaptable than postnatal cardiac outputs. So the fetal echocardiogram is the test, the workhorse that we use for fetal cardiac diagnosis. And the three main objectives are to describe the anatomy, describe the function, as well as the rhythm of the fetal heart. So I'll start with the anatomy, which is the first part, the most immediate goal of the fetal echocardiogram. And the first step of that is to determine what's left and what is right in a fetus. And it can be quite difficult, right? Because the baby is moving all over the place and not still. So we have a very standardized way of doing this. And I believe this is pretty much the way the people do it across fetal echocardiography labs, which is called the Cordes method. It's essentially on the screen, we place the head of the baby on the right and the legs of the baby on the left of the screen. And then we always do a clockwise rotation of the probe, thereby sending the baby's head into the screen and his legs towards us. And then using that, we can know what's on the right, what's on the left, what's superior and what's inferior. It's an extremely critical part of the test because the positioning of all of the organs after will depend on us appropriately identifying what's left and what's right. And this is still done by humans, so there are some errors actually, even in very expert people who do this by rotating the probe the other way, etc. So it's a part of the exam that we get very, very picky about to make sure that it's done correctly. After that, what we do is we apply the segmental sequential analysis. So it's a mouthful, but it's essentially what we do to describe any form of congenital heart disease using any type of modality, whether it be echo, MRI, CT scan, pathology. Everybody uses the segmental sequential analysis because it's a systematic way of approaching congenital heart disease where we know almost everything is possible. So we need to have a very rigid and comprehensive way of describing the heart. It was initially developed by Richard van Praag, who is, despite his name, a Canadian. So that's something to be very proud of. And then further modified by many different doctors, but the one that whose description or modification are stuck the most is Robert Anderson. So the two systems by which we describe congenital heart disease are the Van Prague and Andersonian systems. This is just technical stuff, but that's why maybe if you go from one lab to the other, you'll have different terminology from one place to the other. It's using the segmental sequential analysis, but the language might be a little bit different from depending on what they use. So just to give you an example, across the mountain at Saint-Justine, they use kind of a mix of Van Prague and Anderson, whereas here we're much more in the Anderson type of language. So why do we use this type of approach? It's obviously because it provides a very consistent nomenclature based on the anatomic and morphologic features of the cardiac chambers. Because as you guys all know, the structures are not named after their geographic location. They're named after their morphologic characteristics. So that's why we have to kind of use this type of standardized language. It's a systematic and analytical approach. It's applicable to all congenital heart disease, and it favors understanding and exchange of data among those who are taking care of these patients with congenital heart disease. So the central feature is the segmental part of this approach, meaning that we approach the heart as three main segments. So the atrial segment, the ventricular segment, and the great arteries. And these three segments connect to each other using two different junctions. So the atrioventricular junction and the ventricular arterial junction. And all we're doing is really describing these different elements using imaging. In the fetus, it's most often echocardiography. So the morphological method, which I touched on, was initially described by Lev in 1954, where the cardiac chambers are identified in terms of their gross morphologic characteristics. They're not identified according to the vessel or the valve of entry, nor the relative position, nor in terms of blood conveyed by the chamber, because these are variable in congenital heart disease, right? So all of this to say that we attempt to identify morphologic features of the different chambers to describe the congenital heart disease. So we won't go into like great detail about all of these, but just so you know, if we call it a right ventricle or a left ventricle, it's not because it's on the right or on the left. It's because it has the morphologic features of a right ventricle or a left ventricle. And these can be anywhere. They can be, the left can be on the right can be on the left, they can be superior, inferior. So that's why it's important to realize that in the language that we use. Positioning of the heart within the thorax is very important. So this is just a kind of a reminder to show what we mean when we say levocardia, dextrocardia, or mesocardia. It describes the position of the apex in relation to the chest. So these are kind of some of the configurations. You'll often see situs in the language of congenital heart disease. So what is situs? Situs is of Latin origin, meaning position or situation, and it refers to the fact that the human body is asymmetric and is characterized by chirality. So it's characterized by sidedness. So if you take a person and you slice them in half, what's on the right side will be very different from what's on the left side. And that applies to pretty much all of the organs, including the heart, the lungs. Part of the cardiac exam, as you know, is to have an assessment of that, because one of the important things we have to distinguish is any problems of heterotaxy. So what we call heterotaxy or isomerism. So this is just a schematic to illustrate that. So you can see the normal situation, the visceral situs solitus. So solitus is the Latin term meaning usual. So the usual left and right dispositions. And you can see that the lungs, the right lung and the left lung, are different in their bronchial pattern and their lobulation. The abdominal cavity is also different from left to right, you know, the gallbladder being on the right, the stomach on the left, the spleen on the left. And the abdominal vessels also, you can see the IVC is usually anterior and rightward, the descending aorta is posterior and leftward. Situs inversus is just a mirror image of that. And that's very important to identify because it can be associated with primary ciliary dyskinesia. And then the situation where you have kind of two right sides, or right atrial isomerism or left atrial isomerism. The right atrial isomerism, you can see that the lobulation of the lung is trilobed on both sides. So you have two right sides, so to speak. And these different situations have different implications for prognosis as well as management. And I didn't go into the details of what's associated with that because of the scope of the talk, but I'm happy to do that eventually for another session. So this is just to kind of from CT images, you can see the bronchial branching pattern of the lungs that can identify the situs of the lungs. So in the fetus, how do we do this? We obviously don't see the lobulation of the lung, or we don't see the great detail. We can't see the details of the abdominal situs. But we use this in the situs sweep, the sweep I told you about at the beginning, where we determine what's left and what's right. And we determine the position of the abdominal vessels. And we go off of that to tell us what the situs is of the atria and as well as the lungs. So this is the cross-sectional view that we get of the fetus in the abdominal cavity. And we can see left and right, posterior and anterior here. And we identify usually the gastric bubble, and we identify where the descending aorta is. This is a normal one where the descending aorta is posterior and to the left, and the IVC is anterior and to the right. So we use that to extrapolate what the atrial situs is and the lung situs is, because most of the time they do concord, although there is some evidence that they can be discordant in quite a bit of the cases. Previously, it was kind of a dogma to think that the abdominal situs usually corresponds to the atrial and pulmonary situs, but in recent data we can see that up to 25% can be discordant. So it's quite significant. But this, for our purposes, this is what's used on a daily basis. The next parts of the fetal cardiac exam is essentially focused on sweeping the heart in the different planes to be able to, like we said, identify the structures based on the morphologic method, and then identify the different segments as well as the connections in the segmental sequential analysis. And this is just an example to show you kind of where the probe would go and how these sweeps work and give us kind of different information about the different structures. I won't get into that too much, but you can get like a very good analysis there. So sweeps are kind of the main tool that we have for fetal cardiac diagnosis. So as you can see here, we perform the 4-chamber view. I don't know why it's not playing, but here. The 4-chamber view, which allows us to identify the atrial segment, the ventricular segment, as well as the atrioventricular connections. And then added to that, we can see the ventricular arterial connection. So here we sweep from the ventricular level to the great artery level. And so what we're looking for is, you can see here, this is the left ventricle and the right ventricle here. And if I slow it down, you'll see the left ventricle opening up to the aortic valve and the aorta, the ascending aorta. And then if I sweep further, you can see the pulmonary valve here. I'll go back on it like this. You can see the pulmonary valve opening and closing, connecting to the right ventricle and going the other way. So that's the crossing of the great vessels. This is a sign that's extremely important in excluding well, one of the most critical cardiac diagnosis of transposition of the great arteries. You wouldn't have this type of crossing. And then what's nice in fetal life also is that if you sweep even further up, you can see something called the three-vessel view. And there's a whole way of detecting congenital heart disease just based on the three-vessel view. So the three-vessel view relies on the number, the alignment, and the size of the three main vessels coming out of the heart. So the pulmonary artery from the left, the aorta just right of that, and right of it, the SVC. And usually they go in decreasing sizes. And what's cool about this is you can see this dot here. This is the trachea. And in fetal life, it's obviously the lungs are filled with fluid, so we can see them by ultrasound. And quite often for vascular rings and you know, branching abnormalities of the aorta, we can identify them more easily on the prenatal echo than on the postnatal one. So that's an important part of the fetal exam. Believe it or not, there's still some places in the fetal screening that just do the 4-chamber view, and that's a big no-no. Because when you only do the 4-chamber view, you can, I've laid out that you can very easily miss very severe problems of the ventricular arterial connection, such as TGAs, tetralogy of Fallot, all of this. They can have a completely normal 4-chamber view. So it's never to be used alone. When you add the outflow tract view and the 3-vessel view, you increase the sensitivity of picking up congenital heart disease to 80%. So that becomes really important to integrate those views even for the screening part of things. So then I can show you these are some examples of what we look at in the fetal echocardiogram. So you can see here, we saw the 2D image before. We also make use of an imaging modality called Doppler, which is measuring the velocity of blood in a given area in the sector, and we can have an idea of the hemodynamics of the function of the valves, if there's valve leak, if there's stenosis, if there's holes. Often the Doppler will identify that. We also look at the arch view. So this is kind of a sagittal view looking at the right ventricle, the main pulmonary artery, and the arterial duct. So any issues there we can pick up. And we look at the pulmonary vein connection. Here you can see the color coming here from the one of the right pulmonary veins and one of the left pulmonary veins. Pulmonary veins can be challenging because obviously in fetal life, the lungs are only seeing about 15–20% max of the total cardiac output. So there's less flow in the lungs. Obviously, there's going to be less flow returning from the lungs to the heart. So that can be a technical challenge to imaging the pulmonary veins. So the size and the position of the heart, like we said, is important. There's also the axis of the heart that is becoming an increasingly interesting marker of the presence or absence of congenital heart disease. So normally the axis of the heart is drawn between the anteroposterior sagittal line that crosses the vertebrae and the sternum, and then the axis that goes from the base of the heart to the apex, and that should be around 45%. Some cardiac pathologies can give you a more wider angle or a narrower angle, sorry. So that's something that we look for and that we are encouraging our colleagues who do screening to do more and more of. And then the size of the heart within the chest is also important for many, many reasons, and we'll touch on it a bit later. So the circumferential cardiothoracic ratio usually is less than 50%. And then we can compare the area of the heart to the area of the chest, and that's usually less than 35%. And there's some conditions where that becomes abnormal. So here I'll just show you some examples of abnormalities. So here you can see on the left-hand side, the left ventricle, the right ventricle, right atrium, left atrium. And you can see that the atrioventricular connection is that of a common AV junction. So it's just one big valve opening over the ventricles. So this is what we see in atrioventricular septal defect. In this case, you can see that the ventricles are well balanced. So the ventricles are roughly similar in size. On the right-hand side, I don't know why it's taking so long to play, but you can see the same thing. So the right ventricle here anteriorly, the right atrium, the left atrium, and we don't see really. There's a left ventricle here that is quite a small cavity, and you can see that both atria look to be emptying more into the right ventricle. So this is a case of an unbalanced atrioventricular septal defect. And this is all something that we can pick up. We can pick up on the 4-chamber view. So this is another nice application. You can see the 4-chamber view, and obviously you can see that it looks like a single ventricle common AV valve, so an unbalanced AVSD once again. And what's striking here is that this is the descending aorta right there. And you can see how big of a gap there is between that and the posterior part of the left atrium. If you compare that to the earlier case, there's really not that much of a gap. So that's something that really you usually look for because it can be one of the signs of total anomalous pulmonary vein connection. So here you can see, looking more in detail, you can see that these pulmonary veins come into this confluence just behind the left atrium, and they don't actually connect to the left atrium. So this is a total anomalous pulmonary veins. Further showing that by color, you can see kind of these veins coming together into this confluence and really not emptying into the left atrium. This is another example of anomalies we can pick up easily on the fetal echocardiogram. This is an Epstein anomaly, so of the tricuspid valve. So you can see here the right atrium, the left atrium, the left ventricle, and the right ventricle. You can see this is the tricuspid valve. The tricuspid valve should, in this view, look roughly like the mitral valve. It should have the kind of the same motion, the same valve thickness, etc. And here you can see that it's really not the same. Part of the leaflet here is stuck to the septum, and if you look by color, you can see this massive jet of tricuspid regurgitation coming off of this Epstein malformation. So this is important to pick up because Epstein malformation is one of those pathologies that really gets worse in gestation, and can have a pretty bad prognosis depending on the severity of it. And then we usually look at the ventricular symmetry. I touched on it a bit before, but I'll go over this quickly in the interest of time. So there's some cases where you can see a smaller LV compared to the RV, and this can be a sign of left ventricular outflow tract obstruction or unbalanced AVSD. In other cases, the RV can be bigger than the LV, so then you have to look for tricuspid regurgitation, TAPVD, or ductal constriction. In the opposite case of ventricular asymmetry, where the RV is smaller than the LV, it can either be that the RV is small, so this is an RV obstructive lesion or double inlet type of left ventricle, or the LV can be actually larger than normal. So this can be the case in critical aortic stenosis or mitral regurgitation. So I'll just move on to the function part of things, of the exam. Most often the function is assessed by the so-called eyeball technique. So what we're doing is essentially looking at the myocardial thickening, the cavity area change, the annular excursion, the size of the heart, to make a semi-qualitative assessment of the function. We also look at other signs that can be a sign of cardiac dysfunction in the fetus, presence of effusions, skin edema or reduced fetal activities are also signs of bad function. So these are kind of the views that we saw before, but you can see here easily how we assess the function: 4-chamber short axis view, where you see the left ventricle, the right ventricle, and then the outflow tract view, the right ventricle, pulmonary artery here. And you can see here that everything is snappy, everything is thickening really well. You can see that the area of the ventricle is getting significantly smaller with each contraction. So this is normal function. In some cases, but it's really not, not all that frequent, we can use M mode, which is one of the earlier echo imaging modes, which is motion mode. It's where we shoot one beam of ultrasound in a specific part of the heart, and we get the motion of these structures over time. And what this allows us is to measure the cavity sizes in systole and diastole, and through some equations, we're able to get the shortening fraction for the heart. So we do have some normal values for these patients. It's usually quite simple, familiar to use for cardiologists. However, it does offer significant technical difficulties requiring good alignment. It's very load dependent. So if you have a abnormal loading of the heart, it won't be a very precise marker of function. It's not as precise for the RV, that's for sure. It's really more validated for the LV, and it's difficult to use in complex congenital heart disease. So that's why it's not often done. The use of Doppler is very important in the assessment of function, and that brings me to kind of the way we assess function, cardiac function in the fetus is really integrating multiple parameters that we get by 2D Doppler and extracardiac signs. So this is referred to as the cardiovascular profile score, which is a point-based assessment of the cardiac system. And then it relies on the presence or absence of high drops, the venous Dopplers in the umbilical vein, Ductus venosus, heart size within the chest. So that brings in the importance of being able to assess that. The cardiac function, as we looked at by either looking at the fractional shortening or the diastolic filling pattern, or etc., and then the arterial Doppler pattern in the umbilical artery. These are some examples of showing abnormal, signs of abnormal function. So you can see here in the abdominal cavity, kind of the liver floating around with a lot of fluid around it. This is a case of hyperdynamic cardiac function. You can see a case of severe biventricular hypertrophy. So this is the cardiac mass in short axis. You can see the left ventricle, the right ventricle. You can see how the cavity is actually quite small, and the muscle around it is quite thick. This is just an example of the ductus venosus flow pattern. So this is a very abnormal flow pattern with marked retrograde flow in the ductus venosus, reflecting high filling pressures in the heart. So moving on to the rhythm section of the fetal cardiac exam,
Wadi, before
Why?
we, sorry to
Yes,
interrupt, we're
of course.
getting a bit closer to 2 o'clock. I want to make sure we save time for
For
questions. So I just
questions.
wasn't sure how much you had left.
Rhythm is a few slides, and then just brief words on MRI. I probably have like 5 minutes.
Okay, perfect. Thank you.
All right. I'll go quickly. That's part of the rhythm stuff. So here you can see why we focus on rhythm as fetal cardiologist. Well, it's because rhythm issues account for a big part of fetal high drops and fetal morbidity. Here's some definitions of what's normal and what's abnormal. So we obviously look at the rhythm and the rate. There's some problems that are mostly minor and very common, like sinus tachy, brady, or premature atrial contractions, and some are more major. Those are usually less common, but they can either be too fast or too small or too slow in half of the cases. We obviously can't use fetal ECG. It has been used, but it's a very limited yield. Fetal magnetocardiography is technically very difficult. So we use fetal echo again to assess the rhythm. And we rely on describing the mechanical consequences of electric events to assess the rhythm. So this is one example where we use M mode. Like we said before, we can cut through the atrial segment and the ventricular segment, and we can kind of see, we can see where the thickening is happening here. This is the atrial activation, and then we can see the ventricular activation follow it and get an idea of what the AV conduction is. We have Doppler-based methods as well, where we use the spectral Doppler to get the same timing of these events. So we can use the inflow-outflow Doppler or the SVC aortic Doppler, which harnesses the proximity of the SVC and the aorta in the heart, and we can sample both at the same time. So as the atrium contracts, remember we said the fetal myocardium is quite stiff. There's always a little bit of retrograde flow that goes up in the SVC during atrial contraction. And during ventricular contraction, you get the ejection in the same direction. So this Doppler will look something like this: atrial contraction, ventricular contraction, atrial contraction, ventricular contraction. So that gives you an idea of the AV conduction, the AV conduction time, etc. So here's some examples of arrhythmias that we can diagnose. So this is atrial bigeminy, blocked atrial bigeminy, which is a benign cause of fetal bradycardia. So you can see, using this SVC aortic method, an A wave here that conducts the V wave, and then an A wave here that doesn't conduct. A wave here conducts, A wave here gets blocked. So you're getting quite a slow fetal heart rate, 60 to 90, but this is very benign and usually self-resolves. On the other side, this is an example of SVT, or by re-entry. So we can diagnose this using the Doppler and the M mode in the fetus. So despite all of these, very structured, systematic approaches to fetal cardiac diagnosis, we're still not perfect. This is a study showing, a French study looking at a 10-year period, comparing the neonatal with a prenatal diagnosis of congenital heart disease, and of like 1,000 something patients. They noted that around 29% had a discrepancy between the pre and the postnatal diagnosis. Thankfully, the vast majority were either, they were completely different, but didn't have a big impact on the management, or partly different and didn't impact with major impact on the neonatal care. And then the majority were partly different but didn't really impact the postnatal management. The more long-term postnatal management, around 5% had a kind of a negative type of discordance, where a patient might have been counseled for biventricular repair, etc., or less symptoms, ended up having single ventricle or more symptoms. And then around 2.5% had the inverse, where the patient was thought to be worse than they actually were. So there's still quite a bit of room for improvement. This brings me just to my last point, and I'll go over this quickly. This is fetal cardiac MRI, and it's an emerging field, especially in the world of research, but it's making its way more into the clinical application. This is an example of a fetal cardiac MRI where you can recognize a view that is very familiar and very similar to the echo. From these images, we can get volumes and structure, hemodynamics as well. It's been done by many excellent centers. This is data from the Sick Kids Experience, where they use a Siemens scanner. And the big difficulty with fetal cardiac imaging is that fetal cardiac MRI has to be synchronized, right? It has to be gated to the cardiac activity, and we don't have a fetal ECG to do that off of. So they came up with a very interesting and innovative way to do it, to just acquire data at large, assuming a certain heart rate, and then doing multiple reconstructions in an iterative way until they get kind of the most stable reconstructed imaging. It's a very processor heavy way of doing things, but it yields really incredible results. These are some of the applications that I can show you. You can obtain 3D data sets in the fetus for extracardiac anomalies that would otherwise be very difficult to describe with precision. So this is a case of a scimitar vein, where you can see the scimitar vein draining into the IVC. And then this is total anomalous pulmonary veins of the supracardiac type. You can see them coming back here and then going above to the innominate vein. You can also identify congenital heart disease using MRI, although this was recently kind of compared to the yield of echo, and it's still not as good as echo. You can identify many more structural problems using echo, but it has an increasingly interesting role, especially in patients who are obese and where echo is very, very limited. And the exciting aspects of that is it's basically an MRI, which is a very comprehensive study that can look at hemodynamics as well as oxygen saturations, and then using this data can give us a glimpse into the fetal hemodynamics in different congenital heart disease. And this is obviously work that's being done by Sick Kids, by the group of Mike Seed, and it's providing a lot of insights about neurocognitive outcomes in congenital heart disease related to fetal hemodynamics. Here's a case of transposition of the great arteries, and you can see because of the transposition, the brain gets exposed to mainly much less saturated blood than it would normally be exposed to in the normal situation. And I skipped many other examples of this, but this is a very interesting frontier for fetal cardiac MRI. So just final thoughts: fetal cardiac diagnosis is multidisciplinary. It involves screening and referral. The fetal detection rates have improved with more comprehensive guidelines, but there's definitely still room for improvement. The fetal echo is a comprehensive systematic exam allowing assessment of anatomy, function, and rhythm, but it's not perfect, with the challenging diagnosis challenging to prognosticate still. So with that, I thank you, and I welcome any questions.